Well, hello everybody. Welcome to iCubed. This is episode 21. And here in Arizona, we're beginning to see a little break in that oppressive heat. You will be probably watching this in November, but we're recording it in the beginning of September, and I actually see 70 degrees on the weather report, which is wonderful. I have a new guest this month. Dr. Lipinski, would you introduce yourself a little bit?
Sure. I'm Chris Lipinski. I am 20 years in practice, finishing my program at the University of Pittsburgh in 1998. Went on and did a fellowship for 2 years at Wayne State University in Detroit.
Wonderful.
Practiced at Detroit Receiving for a bit, and I've been in Arizona since 2000. Spending time between Maricopa Medical Center for the first couple of years.
Yay!
And then Mayo Clinic Hospital for the next 14, and then I took a jaunt to Los Angeles and worked at a Kaiser Permanente hospital, and now here at Baywood.
Yes, wonderful. You're a welcome addition to our group.
Well, thank you.
Well, very good. So let's meet our patient.
Okay.
So this is a patient I saw earlier this year, actually. We get this pre-hospital note, it says 60-year-old female, syncope, awake and alert. She has abdominal pain. What do you think of those vitals?
Well, they're abnormal, to be sure.
So we get a little bit more when she comes in. She had a recent diagnosis of uterine cancer, and in fact, she was actually waiting for a second opinion before deciding the course of action. She said that about 3 hours before coming in, she was just sitting on the toilet when she started to pass clots vaginally, and she had severe abdominal pain. She felt faint and she fell to the floor. Now the family was nearby, so they were by her side within minutes. On general appearance upon presentation, she's alert and awake, but she's moderately distressed and she's acutely ill appearing. She's moaning in pain. She's very pale.
Looks like the vital signs.
Yeah.
Okay.
But by the time we get her in the ED, our very first set of vitals seem to have settled down. Her blood pressure 124/89, heart rate is 99, respirators are 28, still a little high, saturation of 100% on room air, and her temp was 36.7.
Okay. What was done en route?
So nothing was done, just the IV. We have a little time to explore. She has a past history of the breast cancer, status post a lumpectomy 2000. She has a history of hypothyroidism secondary to radioactive iodine therapy she received. With regard to surgical history, she's had a breast lumpectomy, as mentioned, and a cesarean. Social history: no alcohol, no tobacco. She doesn't do any drugs. The only medicine she's on is the Norco for abdominal pain.
A very unlikely person to be at Baywood. It's on my list.
You're absolutely right. You're now seasoned Baywood provider.
I've learned the tune.
Yes. So then beyond the general appearance, you take a look at her more closely. I see she's cool, she's pale and clammy, right? Her eyes, she has very pale conjunctiva. She's got proptosis. She has dry mucous membranes. She's got a regular rate and rhythm of her heart. Her abdomen, very tender lower abdomen with guarding. There's no rebound. Her abdomen is distended. In terms of the genital urinary exam, I deferred it actually because she was really in a lot of pain. I didn't want to disturb that, and I wanted to treat that first. But I did notice there was no blood on her undergarment that she had on, so I didn't.
I think that's an important piece of history there.
Yeah, exactly. Neurologically, she was really intact, very appropriate.
Okay.
Yeah, what do you think so far? Yeah.
Well, an acutely ill woman comes in with a syncopal episode who has very abnormal vital signs en route, has really not a ton of comorbidities, save for the thyroid condition and in the oncology history, which is certainly significant.
Right.
My first thoughts are that if she were to, I think the most obvious thing one thinks about when they hear cancer and bleeding is this due to acute blood loss?
That's right.
And I would, hesitate to really, put too much value in that given the fact that you don't see blood on your initial exam, and she's passed a couple of clots, and that is not what would cause such radically abnormal vital signs. So the next thing I would be thinking about is, did she have pulmonary embolism?
Right, good call.
Of course, with the significant tachycardia, the respiratory rate being so elevated. But you would think that a pulmonary embolism of that size might cause her to be a little hypoxemic, which she wasn't.
That's right.
And she wasn't hypotensive.
Good thoughts.
So we'll put that on the list, but certainly not towards the top. The thing that's intriguing is the history of thyroid problems. Certainly need to put that
in the differential.
Of somebody who's tachycardic and ill appearing. Her initial blood pressure was. Well,
in the ED, it was fine. She was never hypotensive pre-hospital, nor upon a presentation to the ED.
Right. So I'm thinking now this is a stress event, with a woman who has a thyroid condition.
Right.
And so a thyroid storm would be something I would consider putting on that list.
Right. So for me, unlike you, I just went and thought, oh my God, she's bleeding to death from a vaginal cancer, right? Or uterine cancer. That was my very, very first thought, but I think you're absolutely right. We have to include those things. I didn't even really think about PE, but that's a great thought. So at this point, the differentials we're talking about are hemorrhagic shock, hyperthyroidism or hyperthyroid storm, PE, an MI, cardiac arrhythmia, sepsis, I suppose, could cause syncope and tachycardia, abnormal vitals like that.
For sure, and I haven't seen a rhythm strip or an EKG. And of course, we're going to need that.
Right.
But I didn't hear that she was having any, chest pains. I didn't hear she's diabetic, so I would be surprised if she'd had an event,
a cardiac event,
a major adverse cardiac event, without really any symptoms north of the diaphragm. So,
for me, my first thought was, call gynae uncle. Well, but I didn't, because they're going to need information. All I have, this is the first 5-10 minutes of meeting this patient, right?
You're not ready to have that conversation.
Exactly. So somehow she's settled. She's vital. Her vitals are okay at this point. She's not crashing in front of me. So we'll proceed. So I ordered the CBC, CMP, your lactate, type in screen. I got an EKG, and I ordered a pelvic ultrasound.
I might suggest in this particular case that I would probably do a bedside transabdominal.
Excellent.
With uterine cancer, you can have rupture, of course.
Absolutely.
So there could be bleeding internally, and you can identify that very easily. Right?
Great idea for someone who's
quick. It's convenient.
I am such a POCUS evangelist that it's surprising to me that I didn't even try that on that day on this patient. But anyway, that is a great idea. So we do get an EKG, and this is the rhythm. This is the actual EKG for the patient. What do you see?
So she has a sinus tachycardia. The rate is probably in the 120s. I'm looking for a delta wave. You're going to throw me a curve here.
This is not a ASEP.
I know. I've been there. Right. I would call this a sinus tachycardia, otherwise normal.
Yeah, it is. It's just a sinus tach or sinus rhythm. I didn't see anything on that. So, she's stable. We're waiting for the results. They come back. Now, this shorthand, I don't even know if the young doctors know how to read these anymore, but this is what I grew up in medicine doing.
I know this very well. I've drawn this a million times.
A million times myself, too. The labs come back. We see the hemoglobin of 7, which we have to remember with an acute bleed, it really doesn't reflect the actual H&H. And the other thing is that we don't know what her previous baseline H&H is, right? Maybe it was 12, maybe it was 13, we don't know. The Chem7 is really not that remarkable. Her lactate's 1.5. So, she's been there now an hour-ish, and her vitals have been fine. This is a night shift for me, and it's busy. I'm running around. Her vitals, the next set of vitals we have in the chart after her presenting one is systolic blood pressure of 112. The heart rate is 97. I go back to check on her. She I discussed the results with her and her husband, actually. She's alert. She's still in some pain. And I talked to her about her results, which we just reviewed, right? She says that she thinks her last hemoglobin a few weeks ago was 5.9. So it kind of alleviated my concern momentarily anyway. She said she got 2 units of blood transfused elsewhere.
We know this from doing, a lot of patient care, that not everything we hear from folks is correct. And
yes, you're
maybe her
right.
Potassium was 5.9.
I think that's an excellent point. So then she tells me that her vaginal bleeding, she thinks, has stopped. So we're trucking along, and that dreaded, Dr. Lee, can you come into room so-and-so? So at 4:45 in the morning, this is, an hour and a half, 2 hours later, I call to the bedside because the nurse says she's become unresponsive. She just came back from the abdominal pelvic ultrasound. Actually, it was just an abdominal ultrasound because she couldn't tolerate a transvaginal.
And we all know that death begins in radiology, in emergency medicine, just so everybody who's listening to this is aware. That's where it all starts.
That is creepy true. All right. So then I go into the room, obviously, and she was briefly unresponsive prior to my getting there. And on my exam, she's looking very pale. She's got a blood pressure of 86, systolic on the monitor. She is somewhat awake. She's moaning. She's extremely pale and clammy. But I feel her pulse. I always do that when I see a hypotensive patient. And her radial pulse is pretty good, actually. So I'm slightly reassured. I look at adult diaper now, and it's soaked with bright red blood. This is not what it was when she first came in, right? So my first thought, oh my God, she's actively bleeding and hemorrhaging in front of me, right? So I had ordered typed and crossed because she had accepted it. So the nurse had just hung the packed red cells, and I said to her, squeeze that in. So I just had the nurse physically squeeze the blood into the IV, right? So then I called out for 2 units of O-neg emergency blood. Just run to the blood bank and bring those back. And then stat call out to the gynecologist on call.
At this point, I would probably have broadened my differential a little bit.
Yeah.
And considered things like sepsis. She's got a bunch of debris that could have led to some endometritis infectious.
Of course. Yeah.
So, I put that on the list, although your lactate was 1.5.
But something to think about, for sure.
Something to think about, especially if it's early on.
Well, my first thought, obviously, and fear was that now she's hemorrhaging in front of me. From what? Did the cancer erode into an artery? Is it? It's almost simulating postpartum hemorrhage, right? I mean, it's just she's soaking with blood.
There is one more thing that I would put on the list: the history of cancer and a history of thyroid conditions, which is a pericardial effusion.
Sure.
Just to put it on. Part of this, I think, the value is assembling a list of high-risk targets, right? To explain physiology.
For sure. So, thank God the gynecologist was very quick to call me back. So I get on the phone with him and I'm explaining the whole situation. The first thing he says, but I'm not gyne-onc. So, of course, I make my pitch, and this woman is hemorrhaging in front of me. You need to come in, basically. And he did say he would come in. And then he said, I might have to put in a Bacri.
A daiquiri or a Bacri?
A Bacri.
Oh, okay.
And I was like, oh, okay.
That was what I was thinking as I read that. I don't know what that is.
Exactly. So, regardless, he's coming in. I'm grateful. In the meantime, she has stabilized. Now they're putting a line in because she's very sick. And at 5:47, I happen to check on her to see how the line is going. And I see on the monitor she's in SVT or A flutter.
Okay.
So the quick way to guesstimate the rate is, as you see, we're all taught this in residency. So it's 150 beats per minute. That's flutter, or it's FCT, slightly slow SVT. So you always have to think flutter when you have a heartbeat around 150, because it could be simply 2-to-1 conduction of a flutter. Flutter is typically 300 beats per minute. So, but I discovered that, and then she's 10 minutes from the OR, so she's off to the OR.
This is slight problem.
Yep. And I looked later, anesthesia cardioverter in the operating room before the procedure.
Okay,
so
smart.
It worked, yep, and it was successful. So Chris, that's the clinical scenario. My screencast always has 2 learning focuses. I try very much to boil things down to 2 simple, or at least 2 focused points that we can learn about through this patient scenario. What do you think the first one is?
Well, I'm going to throw 2 out there,
okay,
which are just in jest. But first is that all sick, complicated patients come in at 4 in the morning when you're on the down glide from your overnight. And then the second is that death begins in radiology. I think that those 2 things are clear. But I think the learning focus here is always be suspicious whenever anybody has a history of bleeding or a potential for bleeding. And as such, chase it down. And I think you very astutely transfused as soon as you heard the story, which is, I do the same thing.
Yep.
I am very quick to pull the trigger on blood transfusion. Because
absolutely.
That's the one thing you'll really get in trouble with if you get too far behind the curve.
Yep.
So in terms of my learning focus, suggestion is to keep a broad differential, look at the low-lying fruit and things that you can correct while simultaneously looking at the potential curveballs that you could get.
Oh, absolutely. So since this iCubed is my product and my creation, it's going to be my learning focus number 1. How about that?
You're the boss.
The Backrib balloon.
Oh!
We're going to learn more about the Backrib balloon than you ever wanted to know.
See, I thought this was going to be a red herring, but apparently not.
There's no red herrings. Have you ever heard of this? You said no.
Not, no.
Yeah.
No.
So neither have I. That's why when the gynecologist said that, I was like, what? And thus, afterwards, I looked into it. So essentially, it's a balloon.
Long rhino rocket.
Essentially, it's a balloon for tamponading intrauterine bleeding. So there's a product made by Cook. It's made for postpartum hemorrhage. And the most common reason for postpartum hemorrhage is uterine atony. You insert the tube through the cervix into the uterine cavity with ultrasound guidance. Once you have the tube placed in the uterus, you will inflate it up to 500 cc's with saline in order to tamponade the uterine bleed. In fact, it can insert it via the C-section scar or wound. Now, none of this will be performed by ER docs, obviously.
No.
But I just found it very fascinating, and in this patient, it was effective. They took her to the OR and placed the Backrib and stopped the hemorrhage.
Right. I'm trying to think of what I would do, if I were on, a desert island with this patient, and with an interventional radiologist, of course, who's stranded with me. Well,
there's definitely talk about in the third world country what happens. You can use a condom.
Sure.
Yeah. So you put the Foley catheter inside a condom, and then you infuse 500 cc's.
Oh, that's clever.
Yeah. So the Backrib balloon, 100% made with silicone material. So those who are allergic to latex, you don't have to worry about that. It's created for postpartum hemorrhage. It is still a leading cause of maternal morbidity and mortality in our world. Most common cause of PPH is uterine atony, and it's really just used for temporary control or reduction of the bleeding after failed use of uretotonics. And it's really just a sort of a transition to get to definitive care is what it's used for. It should be used or placed in the L&D or OR suite, and it's placed under bedside ultrasound. You can place it through the C-section incision. The complications are very rare, but it includes uterine perforation infection. Apparently, there are studies out there that show Backrib is a successful method for postpartum hemorrhage control, and it has to be removed before 24 hours or less. Learning focus number 2. What do you think? You will never guess.
I am so curious to find out what learning focus number 2 is. Oh, actually, I was going to suggest this, but I didn't want to be too pedantic about it. But yeah, I mean, certainly
TXA?
tranexamic acid. And when I was at Mayo Clinic, we did tend to use the procoagulants, not uncommonly.
It never came up in my mind that night. However, when I was reviewing this chart, I saw curiously that the anesthesiologist had given a gram in the OR. About a year ago, I'd done a screencast with Dr. Fulton all about anticoagulants and the reversal of anticoagulants, because I had a patient that had dental bleeding that would not stop, and that patient was on Xarelto. Mm-hmm. So we went through a whole thing about anticoagulants and reversal. So fibrin is a clot, and our plasminogen in the bloodstream gets cleaved to plasmin, which is what cuts up the fibrin clot, which produces FDP, which is fibrin degradation products, right? Well, then what TXA does is it interrupts the cleaving of plasminogen into plasmin. Therefore, it stops the cleaving of fibrin into FDP, right? So essentially, TXA stops the clot from being cut up into little pieces. It prevents clot breakdown. So Rebel EM did a post last year where they reviewed a meta-analysis which was published in Lancet. It was a TXA meta-analysis of 2 large studies, CRASH 2 study and the woman study. In the combination of these 2 studies, there were 40,000 patients enrolled. Salim Orzail had some take-home points, which was, number 1, most deaths in trauma or in PPH from hemorrhage occur within hours of bleeding onset. The mortality benefit of TXA appears to be diminished over time and is lost at 3 hours after major hemorrhage starts. There is no major adverse effects in this meta-analysis. So just briefly, the CRASH 2 trial had 20,000 patients enrolled. They gave TXA 1 gram IV loading within 8 hours of the injury, and then another gram of TXA over the next 8 hours. I had talked about that more at length in my previous screencast. So I'm going to talk a little bit more about the woman trial. The woman trial also enrolled 20,000 patients. It was published in Lancet a year ago. They gave 1 gram of TXA slowly. A second dose can be given in 30 minutes if the patient was still bleeding, or if the bleeding started again within the 24 hours. It was a randomized controlled trial with 20,060 patients. The deaths due to bleeding with TXA was 155 out of 10,000, or 1.5%. Deaths due to bleeding with placebo was 191, or 1.9%. If the TXA was given within 3 hours, the deaths were 1.2% versus 1.7%, and there was no difference in the adverse effects. The author's interpretation was that the TXA reduced death due to bleeding in women with postpartum hemorrhage with no adverse effects. When used as a treatment for postpartum hemorrhage, TXA should be given as soon as possible after the bleeding onset. Even though my patient is not postpartum hemorrhage, it almost mimics it. So I think that we can probably extrapolate the information we gather from the woman's study. So to end the scenario, she went to the OR. The gynecologist placed the back reed. The bleeding stopped. Patient was admitted to the ICU. And then she was transferred that day to the University Hospital for a higher level of care. Okay, and they did a CT abdomen there, and look what they found. So that's the uterus, and then the balloon
is somewhere else.
It is in the left side of the abdomen.
It is certainly not where I would have expected it to be.
Right.
So learning point 3 is to be very careful where you place a back reed balloon.
Well, so we don't know if it displays. We don't know. I did not do a CAT scan in the hospital, in our hospital. That was the very first CAT scan that was performed. So she was transferred from our OR, our ICU, to them before that CAT scan was done. Anyway, she was taken to the OR. They performed a radical abdominal hysterectomy with lymph dissection. The back was removed. There was exploratory lap. She was discharged home on hospital day number 8. So that's it.
Very interesting case.
Yeah.
I learned quite a bit from this.
Great. Have you had any cases like this? Really serious vaginal bleeding? You remember?
I have. Actually, I had a case of uterine tumor that was very large in an older lady. This was in Los Angeles, and she had just persistent bleeding, and it was a tumor that was matted within the pelvis, so there really wasn't any surgical intervention you could do to really resolve the problem. So she was essentially treated with transfusions, radiation, and ultimately hospice care.
Yeah. So did she come to the emergency room?
Yes.
Bleeding?
Yes.
I see.
Yeah.
So in the ER, your management was just to transfuse her?
Transfuse and rely on suggestions from oncology and gynecology.
Right. Well, thank you, Chris, so much for joining me. I am honored that you accepted my invitation to come. Thank you, everybody, for watching this month. I hope that you learned something, as I did, going through this case and researching it. If you see me at any conferences, don't hesitate to come and say hi. I promise I don't bite.
Dr. Lee does not bite. At least in the 6 months I've been here, I've not observed that behavior.
I don't bite. No, I don't. So just say hi. Thanks again for supporting this screencast. We'll see you soon. Bye.
Goodbye, everybody.